You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 4th, 2024. This week, I'll do some listener feedback on late gadolinium enhancement pre-defibrillator, PFA for AF ablation, CTO-PCI, endovascular ablation of the greater splanchnic nerve in HFpEF, and data sharing. First up, some listener feedback on LGE before ICDs. Last week, I reported on a meta-analysis of observational studies of LGE in patients who had non-ischemic cardiomyopathy. At issue was the concept of risk stratification. EP doctors care about predicting risk because we are asked to consider ICD placement in these patients. Now, at this moment, and for the past 2 decades really, we base our ICD decisions solely on left ventricular ejection fraction, EF. EF was an entry criteria for the seminal ICD trials. And when the seminal ICD trials were done, EF was the best risk stratifier we had. Times have changed, of course, and now many patients with newly diagnosed non-ischemic cardiomyopathy get a CMR. CMR detects late gadolinium enhancement or LGE or SCAR. Now, the JAMA meta-analysis of more than 100 smaller observational studies reported a strong correlation between SCAR and ventricular arrhythmia, sudden death, heart failure, and overall mortality. And it's a compelling association because epidemiologic data comports with biologic plausibility, namely SCAR can act as a nidus for reentry. Regarding the meta-analysis that found strong associations of LGE and future risk, I spoke in pretty optimistic tones about the possibility of using LGE on CMR to guide ICD recommendations. Of course, an ICD recommendation is basically a surrogate marker for arrhythmic risk, a surrogate marker for prediction. The failure of the 2016 Danish trial of ICD versus no ICD in patients with non-ischemic cardiomyopathy to confirm an ICD benefit could possibly be explained by the fact that modern-day non-ischemic cardiomyopathy patients have a lower arrhythmic risk compared to 20 years ago. The lower rates of arrhythmic death may be because medical therapy is better, or it may be because EF is not the best risk stratifier. Had we used SCAR burden as measured by LGE on CMR, we may have enrolled higher risk patients and given an ICD a better chance at lowering mortality. In fact, there are at least 2 ongoing RCTs that are going to use LGE to guide ICD decision making. Now, all of that was a bunch of words to say I was swayed by the meta-analysis and the idea of risk stratification using LGE. However, an expert in imaging and an AI researcher sent me a note of caution by email. He argued that A, LGE tracks pretty closely with LVEF, so even with adjustments, many of the observational studies included in the meta-analysis could be confounded. He also argued that LGE is difficult to quantify. My expert writer noted that the precision or intra-class correlation coefficient, ICC, for LGE is not so great. Perhaps even more variation than left ventricular ejection fraction. And the reliability of measurement is really important. I make fun at work all of the time when patients worry about an ejection fraction measure. Say it was 43% and now it's 41%. I tell them that this is much like the data showing judges give harsher sentences before lunch because they're hungry. The reason I share this reader feedback is that I did not know there was reliability issues with LGE reporting. Let me share just as a copy and paste my colleague's conclusion because it's so good. This person wrote, "A central thesis of medical imaging is that in the current state, variations in medical impressions is much more driven by human variation than image quality. I don't think one can say SCAR is better just because it's a more expensive or fancier technology." And I could not agree more with this sentiment. The thing with ICDs is there's room for improvement in patient selection. There always has been. The vast majority of ICDs that we place for prevention are never used. And the vast majority of sudden arrhythmic death occurs in patients who have EFs greater than 35% and don't have ICDs. So prediction is a tough game. I hope technology can help us do better with patient selection. All right, next topic is pulse field ablation for atrial fibrillation. I have an announcement to make. I may have been overly skeptical of a new technology, and I know that's hard to believe. The journal Circulation has published the Admire pivotal trial of pulse field ablation to treat PAF. It's actually a great name of a trial, but it's not really a trial. It's merely a non-controlled study of 277 patients who had ablation using a novel catheter made by one company. Now, while this sounds like a highly specific EP topic, I'm going to make some general medical lessons out of it. First, PFA, as I've said before, is a new way to destroy myocytes. Instead of thermal energy like RF or cryo, PFA uses electrical energy. Think shocks. The electrical energy creates pores in myocardial cell membranes, and it leads to cell death. We call this electroporation. In fact, the first ever ablation ever used DC shock to ablate the AV node. Now, the chief putative advantage of PFA is its cardioselectivity. You can ablate the atria without causing pulmonary vein stenosis or damage to the esophagus or phrenic nerve. Proponents of PFA argue that avoiding these three complications makes PFA safer than thermal ablation. And so here comes the first EBM lesson. The proponent's safety argument is likely true, even though the evidence does not directly support it. Wait, how can that be? Here is how safety can be better without seeing a signal in the evidence. When you look at PFA studies, primarily Advent trial, which I covered in the February 2nd, 2024 podcast, and I'll link to it, in Advent, the safety events were similar in the thermal or PFA arms. The most common AF ablation complications, such as vascular damage, pericardial effusion, and stroke, were similar whether you used PFA or thermal ablation. But these are not the most worrisome adverse events of AF ablation. The thing that keeps electrophysiologists up at night is roughly a 1 in 5,000 to 1 in 10,000 risk of atrial esophageal fistula, which usually happens weeks after the ablation and results in death in most cases. And the worst part, most ablation folks, including myself, feel like the risk of damage to the esophagus is purely stochastic, meaning it's just happens by bad luck. And bench studies show that PFA does not cause esophageal damage. You can put a PFA catheter on an esophagus and turn it on, and it doesn't damage the esophagus. But given the rarity of atrial esophageal injury, trials of a few hundred patients could never sort out this safety signal. Therefore, on paper, the safety of PFA looks similar, yet not having to worry about a rare but devastating adverse effect confers a major safety advantage. Consider, for instance, the probability of esophageal injury and death from the point of view of the operator. Using thermal ablation, if the risk of causing death is 1 in 5,000, and an operator does 250 AF ablations per year, then it would take 20 years to cause one death. Now, that might sound like a long time, but I personally can testify that 20 years happens very quickly. And remember, Regarding this safety feature, we often ablate middle-aged people, 50-year-olds. Now, for hospitals and somewhat for docs, AF ablation is one of the most lucrative cardiac procedures there is. Hence, there has been an arms race to get PFA catheters on the market. The ADMIRE study was Johnson & Johnson's regulatory study. At 30 centers, 277 patients with paroxysmal AFib had PFA ablation with the Johnson & Johnson catheter. There was no control arm. Control was historical. The new catheter, which looks like the old-fashioned lasso mapping catheter, allowed for PV isolation. Procedure time was similar to standard ablation, about 81 minutes. And the 12-month freedom from AFib was 75%. Adverse events, however, occurred in 8 of 272 patients. That is a 2.9% complication rate. 3 patients had tamponade, 2 with vascular issues, 1 pericarditis, 2 strokes, and 1 TIA. So the marketing message will be that the catheter is both a mapping and ablation catheter. And since Johnson & Johnson makes the most common mapping system, doctors can create a map and ablate and then a post-ablation map. And this makes for great pictures to put up on Twitter, which I don't recommend doing, but people do it anyways. And it also reduces the number of catheter exchanges through that stiff, thick sheath in the left atrium. The other marketing message will be that 1 in 4 patients in this study had ablation without fluoroscopy. Doing ablation without X-ray is a parlor trick. It's not significant. Doctors brag about it, but then the same doctor who's bragging about doing zero fluoro ablation does a BIV device and gets 30 minutes of full-on direct X-ray exposure. So a couple minutes of X-ray at the leg with a shield during an AF ablation is nothing. The problem with the marketing message of fewer sheath exchanges, which is a good thing, is that 3 patients in this trial or study had cerebrovascular events. That's way too many, given that these were 61-year-old patients with paroxysmal AF. The authors say that the stroke rate will improve as operators get more experience. Maybe they will, but these are already experienced operators, and I suspect many have been doing PFA with other companies' devices. Now, all that said, where I changed my mind, I'm now 2 months into my experience with PFA, and I like PFA. It's fast, the signals go away quickly, patients don't get a lot of chest pain afterwards, and not worrying about causing death from an esophageal fistula 3 weeks after the ablation is a very nice thing. Even though the absolute risk of causing this is very low, it's not zero. I've spoken to many European colleagues who have more experience with PFA, and they say that the durability of the lesions is still an issue. Some early and small studies have shown that PFA is no better than thermal ablation in durability of the PV isolation. In sum, I like PFA's ease of use and avoidance of esophageal injury. I am using it, but I don't think it's a revolutionary breakthrough. It's incremental, which is okay. I forgot to say, though, that PFA is far more expensive, but in the U.S., if you compare it to TAVR dollars, it's probably not all that bad. All right, next topic is PCI for chronic total occlusion, CTO. The up-and-coming journal Eurointervention has published a 3-year outcomes of an RCT comparing revascularization and O versus OMT optimal medical therapy for chronic total occlusion. It's called the Euro-CTO trial. First author, Gerald Werner. This will be about 400 patients with a chronic total occlusion randomized to optimal medical therapy, OMT, or OMT plus PCI of the CTO. The study has 2 primary endpoints, a quality of life Seattle Angina Questionnaire, SAQ, that was done at 12 months and already published, and a MACE or composite of CV death or MI at 3 years. The authors have published in 2018 the results of the SAQ part, and at 12 months, there was a greater improvement of angina with PCI as compared to OMT. This was in angina frequency and quality of life. And complete freedom from angina was also more frequent with PCI. It was like 71.6% versus 57.8%. Notice that optimal medical therapy completely relieved angina in nearly 60% of patients. So the 3-year results were what was reported last month. Couple of things about trial procedures. There was 2-to-1 randomization, so more patients in the PCI arm. Also, all non-CTO lesions were treated before patients were randomized. Crossover from the medical therapy to the PCI arm occurred in 7.3% of patients at 1 year, but 17.5% by 3 years, so a lot of crossover. The results. At 3 years, the incidence of cardiovascular death or MI was lower in the medical therapy arm, 3.7 versus 6.2%. However, that p-value was not statistically significantly different. And looking at a per-protocol analysis, the difference remains significant. Medical therapy 5.7% versus PCI 4.7%. Overall, major adverse cardiac events were more frequent with the medical therapy arm, and this was almost double, 21 versus 11, but this was largely because of ischemia-driven revascularization. The rates of stroke or hospitalization for bleeding were not different between the groups. There were, however, 6 cerebral ischemic events reported, 1 in the medical therapy group, 5 in the PCI group. Okay, so my comments. The authors of this study see it differently than me. They argue in their paper that PCI of the chronic total occlusion improves quality of life at 1 year, and it did not associate with any worsening of outcomes at 3 years. So, full speed ahead. Let's help our patients, and we'll vanquish their angina, and we won't make them any worse with outcomes. But I'm not exactly seeing the paper like that. I would argue that the first-year results of the Euros CTO trial can be completely discounted because it's a procedure versus tablets in an unblinded study. The procedure group is faith healed, and the medical group is PCI subtracted. The medical group has subtraction anxiety. By the way, this is exactly why ischemia-driven revascularization endpoints were higher in this trial and also higher in FAME2. Now, for the angina results, not only does a lack of placebo arm bias the results for PCI, so does looking at angina at only 1 year. Courage was clear on this. The Courage trial showed that angina differences favoring PCI over medicines waned by 2 to 3 years. So, rather than saying MACE outcomes were not worse at 3 years, I would say that an aggressive PCI procedure did not improve MI or cardiovascular death over medical therapy. In fact, in the intention to treat analysis at 3 years, the rates of MI or CV death were 3.7% for meds versus 6.2% for PCI. They don't give us a hazard ratio, but it's substantially in favor of OMT, though not statistically significant. I wonder where the hazard ratios are in this paper or journal. The results of Euro CTO is similar to Decision CTO, which also found no outcome benefits to CTO-PCI. The Euro CTO authors do tell us and cite the rationale and design paper of the next trial, the ischemia CTO trial. This will be led by a team in Denmark and Sweden, and it will be another trial looking at outcomes with CTO. I'm pretty pessimistic given these 2 trials. All right, here's a brief topic that I didn't know about, greater splanchnic nerve ablation for HFpEF. Now, I must be riding my bike too much early in the morning because I missed the idea that RF ablation of the greater splanchnic nerve could be a treatment for HFpEF. JAMA Cardiology has published the results of a trial called Rebalance HF, which is sham-controlled, so good for them. 90 patients with HFpEF, median age 71, randomized at 15 centers. The procedure is something like this: femoral venous access, catheter up the IVC, through the RA, to the SVC, then down to the azygous vein, retrograde, down to T10 or T11 intercostal veins, then you ablate. Sham does all this but doesn't ablate. The idea with greater splanchnic nerve ablation is that temporary blockade of this nerve in acute decompensated heart failure and chronic heart failure have demonstrated a reduction of cardiac filling pressures at rest and exercise. Think lower preload. This is thought to be driven by a greater degree of vasodilatation, especially splanchnic venodilatation with increased abdominal blood pooling and resultant reduction in stressed blood volume. Rebalance is a phase 2 study, so the primary endpoint is a reduction in legs up and exercise pulmonary capillary wedge pressure at 1 month. And the overall results were disappointing. The primary efficacy endpoint did not differ between the splanchnic nerve ablation arm versus the sham. There are also no differences in the secondary efficacy endpoints. The authors make note of a possible heterogeneous treatment effect, both in the paper and in the tweet that went out to the public. About half the patients had an EA ratio of less than 2. They had the lowest orthostatic pulse pressure and the greatest ability to augment cardiac output with exercise. This group of patients, which corresponded to half the study group, had better outcomes with the splanchnic nerve ablation than did sham. So my comments. Okay, there are a few things to say here. First, I'm happy that JAMA Cardiology published a non-significant trial, and I really want to emphasize that. I like it because it gives the impression that medical science is being done to answer questions about nature, not just to design bias studies to show something profitable works. Second thing, right off the bat, in the development of this procedure, we start with a sham-controlled trial. I like that. Imagine the counterfactual here. Imagine a scenario, a trial, like the CTO study I just covered, wherein one group gets this double-secret retrograde azygous vein ablation, and the other group gets these little boring white tablets. That would be a ridiculous comparison. So I say good on the authors for using the placebo procedure, the sham procedure, so early on in the development. As for the overall results, it's a negative trial. The authors give us a responder analysis, and the right answer here is not to make causal inference because trials are not powered to sort out signal from subgroups. Instead, the right answer, if you think this is a plausible finding, is to pursue another trial randomizing exactly these patients with these characteristics. Okay, I don't know a lot about splanchnic nerve ablation. To those who have knowledge about this procedure, please let me know if I got this right. I covered this topic because I love seeing RCTs lead the way in the development of new products. All right, final topic today is on data sharing. Circulation Outcomes has published a cautionary note on data sharing. The two authors, Dan Kramer and Brahmaji Nalamathu, are academics whom I have a great amount of trust in. Now, I am not sure what the stimulus was to opine on data sharing, but they definitely make the case for caution. I have been very much a pro-data sharing person. Dan and Brahm make the case that data sharing has its problems. Let me first say why I believe data ought to be shared. One reason is to simply check the work for simple and honest mistakes, right? Second is to create a mindset that if you're being watched, call it the Hawthorne effect. If you know people are going to review your work, you might be more extra careful with it. Third reason, I have covered on this podcast numerous times the incredible flexibility in analytic methods. First, I mentioned Brian Nosek's work, who published the Many Analysts One Dataset paper, showing that 29 teams of expert methodologists can analyze one dataset 29 different ways, and this could get to different results. And then more recently, I did a podcast with Canadian researcher Dr. Dana Zaratker, and she's done similar work with nutritional epidemiology. If data was open, researchers could A, justify their choices, B, reanalyze data. If it is different from the primary results, then we could have a public discussion. Those who say that this may undermine or confuse the public earn my scorn, because this is exactly what happened in the pandemic, wherein debate was disallowed and trust in health and medical evidence was shredded. I strongly encourage everyone to read Drs. Kramer and Nalamathu's piece. They make strong points. First, they make the point that FDA reviewers often have access to raw data. So when it comes to, say, drug trials, these data are being reviewed by an independent source. Their reports also from the FDA are publicly available. They also make the note that data sharing does not guarantee that the primary study findings, the data that should be of most compelling scientific interest, be reported compared with what might seem to be more interesting or positive secondary findings. And I love their idea that for privately funded work, institutional review boards, for example, could grant local recruitment authority only if study sponsors commit in writing to reporting the primary study results as stated in the study protocol, as dictated by the pre-specified analysis plan. But this policy solution to underreporting also does not require any sharing of data. And I strongly agreed with Kramer and Alan Matthews' cautions that willy-nilly reanalysis could lead to sloppy papers and even p-hacking. But my counter to that is that there should be pre- and post-publication reviews that would prevent this from happening or limit the influence of such flawed analysis. I would even argue that debunking flawed papers has a positive social value. For instance, the TIMI group was motivated to address a reanalysis of the Fourier trial. While they may not have liked doing it, the public learned a lot about critical appraisal and trial conduct. And my final point, I am least moved by the argument that primary data collection is hard and that people spend a lot of time and sweat doing it. So other people, these so-called data parasites, and that's my word, not theirs, should not just be able to come in and easily get the data to use without doing the work. To me, the potential value in finding important discovery trumps personal goals or hard work of the previous researcher. So that's it for this week in cardiology. As always, I'm grateful that you listen. Thank you for the feedback that I'm getting. I really appreciate that. I learned from it. As always, if you like this podcast, please take the time and write us a review. Even 1 or 2 sentences help others find us. Until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.